Well, good morning, everyone. Thank you, David, for your welcome. It is really a pleasure to be back in Oxford, where, as you've heard, I was a clinical student, house officer, SHO, and research fellow. And I guess much of what I now know about surgery, I began to learn in this place and from some of the people who are in this room. But one thing I don't think anyone ever told me when I embarked on a career as a surgeon was that when you are a surgeon, some really, really bad things will happen to you because of the bad things that happen to your patients. Because things going wrong in surgery is part and parcel of surgical practice. And it struck me after I've been a consultant for a few years that really this is an area which we know very little about, which people talk about very seldom, but which has a great impact on us, not only just on our own well-being, but potentially on our performance and our subsequent decision-making. And I think it's fair to say that in most surgical units, if you're fortunate, when something goes wrong, your colleagues say to you probably up to 4 things, which are, you're good, bad things happen in surgery, let me tell you about a bad thing that happened to me, and get back on your horse again. And it struck me when something bad happened to me that that probably wasn't enough, and that in this day and age we can do more than that. But we can only do more than that if we can really understand how surgeons of different personality types, different makeups, are impacted when things go wrong. And so about 3 or 4 years ago, I began a conversation with the Professor of Psychology at Bournemouth University, and that began a research collaboration. And we now have 2 fully funded PhD students, of whom Kate is the first. And so I'm going to hand over to Kate now to tell you a little bit about what we've been doing in Bournemouth, and in particular, how we'd love it if you and your departments could help us.
Thank you very much. I think it's very important that I start by re-emphasising that I am not from a medical background. So this has been, over the last year and a half, a roller coaster ride for me, and a massive and a very steep learning curve. But I started my research in the way that I'm sure most people start their research, with dipping into the literature that was available to me. And I started off, whether you love them or hate them, with 2 books. So I'm sure that many people in this room will have read them as well. The first one, Atul Gandi's Complications, and Henry Marsh's Do No Harm. Now, the big thing for me was how they brought into focus this idea that when harm is caused to a patient, it can really cause harm to a surgeon as well. This was then further highlighted to me as well in an article that was written by Professor Sir Norman Williams in the Annals of the Royal College of Surgeons, when he wrote an editorial piece about the incarceration of David Sellew when he was imprisoned for gross negligence manslaughter. And he talked about how surgeons are required on a daily basis to make decisions which, if wrong, have the propensity to cause harm. He talked about how when complications or errors occur, of course, they can harm a patient. They can harm a patient's families. It can be devastating and life-changing. But he remarked how it is seldom appreciated the effect that that can have on the surgeon as well. Surgeons are expected to respond to the challenges of continuing effective patient care after adverse events, as well as dealing with patients' families, with colleagues. And there are often standard protocols in place when dealing with patients who have been harmed. What there isn't so much of, though, and what isn't as clear, is how surgeons need support after those events. In the books, what was really clear is that when things go wrong, the majority of people are able to utilise tools within their arsenal to pick themselves up and continue. That there are some innate, amazing psychological traits within surgeons that do allow them to flourish within a very high-stress environment. What became apparent, though, and especially one of the chapters within Atul Gandhi's book, which is When Good Doctors Go Bad, is this idea that one mistake or one negative event can actually lead to more, and how it can really deteriorate subsequent patient care. And we see this very clearly with burnout. And both books cover that topic of burnout and how when intervention strategies are possibly needed, but are not implemented effectively enough. I'm going to talk a little bit about the research that is currently available. And what becomes really clear, if you just go onto Google Scholar and you put in surgical psychology, that the majority of things that will come up are about patients. So the impact on patients when things go wrong, preparing for surgery, recovering from surgery in a psychological capacity. It's all focused on patients, especially so when you look at research that's been conducted within the United Kingdom. What we are really missing, however, is the other side of that coin, the impact on surgeons. One of the first research papers that I read when I started doing my PhD was by Albert Wu. So he is in America, and he was the first person who coined this term of surgeons being second victims of adverse events. One of the things that he also talks about within his paper is how he sees it that there is no place for mistakes within modern medicine. And I understand that, I do. If you are dealing with someone's life, then you can't afford to make a mistake. However, what this does is within a culture that imbibes that ethos, it makes there be a much higher level of stigma associated with mistakes. Now, I don't want to go into this in too much detail because I do think it's been overdone, but when I read that, what it really brought to my mind was the link between surgery and aviation. Now, I grew up with a father who was an Air Force pilot and then went into airlines. And one of the things that he talks about is the culture, the just culture that they have within aviation. So this idea that you have a certain amount of time to report incidents when they occur, and you are then protected from that incident by the company that you work for, by the Civil Aviation Authority, for having full disclosure. And what that does is it allows people to learn from mistakes, and there's a whole human factors element in that, which I'm not going to go into. But the biggest thing there is that it removes the stigma from making a mistake. Now, I'm aware that particularly here, there is a fantastic reporting protocol in place for when adverse events occur. But unfortunately, that's not the case worldwide, nationwide. And what we want to do, what we're hoping to have a little bit of impact on if we can, is making it okay for people to talk about errors and complications, to remove the stigma from the situation. And that stigma isn't just about making mistakes, but also about mental health, illness, needing help and feeling that you're able to access the support that is available to you. And this links in with Wu's view back in 2000 that we need to make sure there is a transparent and candid culture regarding everything within healthcare, but specifically for him, what he was looking at was this idea of mistakes and coming forward, talking to patients, talking to colleagues, and dealing within ourselves. Now, the research is quite split in how it presents surgeons. The majority of the research follows the line of Albert Wu, and it looks at this idea that surgeons are second victims. What is emerging, however, and what I'll talk about in a minute, is this idea that surgeons are actually resilient individuals. And I find this really exciting because this is something that I want to look into in much more detail. This idea that actually surgeons have something innately within them, whether that is something that is trained through surgical training or whether that is something that is selected for and that allows surgeons to become surgeons in the first place, but it allows them to thrive within a high stress, a very difficult work environment. Now, looking a little bit more at the second victim literature. So 12 years have passed since Albert Wu's first paper was published, and he decides to come back and basically do a bit of a literature review on how his concept of second victims has been trending throughout the literature. And his findings were that within the papers that he looked at, within the literature that had been published, when things had gone wrong, so following adverse events, there was a prevalence of between 10 and 40% of individuals who would class themselves as second victims. So people that had been negatively impacted by the adverse event that had occurred. Now, he found in his research that the reactions could have been emotional, so people were reporting high levels of feeling of guilt, of depression. They could have been cognitive, so people were talking about intrusive thoughts, rumination, counterfactual thinking. And some of them were behavioural. So they got people changing practice. They were becoming risk averse, much more conservative in the procedures that they were carrying out. They were also finding that people were utilising different forms of coping strategies as well in terms of behaviour changes. Now, some of these were positive. So some of the coping strategies implemented were things like turning to colleagues and asking for support, asking for more training, going back over that procedure just to make sure that they were doing everything correctly. Some of them, though, were what we would call maladaptive or defensive. So maladaptive coping strategies are basically your bad coping strategies. So the ones like going home and drinking an entire bottle of wine, or over-exercising, or having counterfactual thinking experiences where you're constantly thinking, what if, what if, what if? Going back over it. You might find that people are just avoiding doing that operation again if there is a problem. Basically, though, what they found by looking at all the literature that occurred in that 12 years, it was becoming much more apparent that when things go wrong, there is a significant impact on surgeons, which can then have a knock-on effect on colleagues and patients after the event. And what was becoming really, really apparent is that individuals in that situation, so the 10 to 40% of people that are negatively impacted when things go wrong, are getting the support that they need. Over in the States, Schoenfeld did a study that actually was a survey launched in 2006 that went out to loads of people, basically. They got a 31% response rate, and their participants was 7,905. So a fantastic response rate, and it's provided a wealth of data within the United States regarding the mindset of US surgeons. So the first paper that was released from this massive data set was about burnout and perception of errors. They found that within that sample, so within the 7,905 people, that there was 9% of them had reported that they had made a perceived major error within the last 3 months. And when they looked at that 9% of the sample and looked at their levels of burnout and their mental quality of life, so they used the Maslach burnout inventory and the brief quality of life scale, they found that actually there was much higher levels of burnout and negative impact on quality of life in those 9% than there were in the rest of the population. So it's showing that there is a strong relationship between errors and burnout and negative impact on quality of life. So we're beginning to see a pattern here that there's actually evidence to support what has up to this point been really anecdotal reports of the impact on surgeons. Now, because it was such a large data set, Scharnefeld was able to use it for other things. And one of the things that they looked at within the United States was how there is a disproportionate cause of death within US physicians of suicide. So this isn't just surgeons, this is across the board within medicine. They did, however, find that surgeons had twice the rate of suicidal ideation than the general population, with that rising to 3 times as much with surgeons that were over the age of 45. Of that sample who were reporting having suicidal thoughts, only a quarter of them, so I think it's 24.6%, sought psychiatric or psychological help. And this brings us back to my earlier point about this idea of stigma. If there were a culture in which it was okay or people felt safe and able to come forward without fear of judgment, then we would be able to raise that number from a quarter to much higher. And that's not just within healthcare, that is among the general population with regards to stigma and mental health. Of that number who reported suicidal ideation, 60% of people felt that they were unable to come forward because they felt that that could have a negative impact on their ability to practice, and that they might have their medical license revoked. There was also, as I'm sure you'll probably have guessed, a significant relationship between recent suicidal thoughts and symptoms of depression and degree of burnout. Now, up till now, all of the research that I've spoken to you about has been outside of the United Kingdom. There has been very little done in the United Kingdom, so we have no real idea of whether the findings that I talked about with the large-scale survey done by Scharnefeld or previous research, whether we can fit that into an NHS setting, whether that links to how in the UK surgeons are trained. And the biggest bit of insight that we really have in terms of research that's been done was by a PhD student at UCL. And the research team, Pinto, Fiers, Bicknell and Vincent. And this was researched in the UK. There are 2 parts. So the first one was an interview-based study. So a qualitative study with quite a small sample, so 27 surgeons. They were from 2 trusts within the UK, and they were vascular and general surgeons that she interviewed. And from the findings, we were able to see that actually there's a strong correlation with findings from previous research, that when negative events happen, when adverse events occur, they reporting a significant negative impact on both their personal and professional lives. She found similar behavioural changes to previous research, so the fact that surgeons were becoming more risk-averse. They were reporting that they were becoming more conservative in their approach and that they were becoming fearful of a repeated event. In terms of themes emerging with regards to emotional affect, there were strong emotions brought across by surgeons. The most prevalent of that being guilt. So this was a theme all on its own within the research. And it was this idea that you have caused harm when the whole reason why that individual went into that job in the first place was to remove harm from individuals. As well as guilt, though, it was reported high levels of anxiety, disappointment in themselves and in the team that they were working in. And then there was also a report of anger. So this was a theme that emerged. This was particularly prevalent in younger surgeons and trainees, but they were reporting that they didn't feel that they had been given the support that they needed, and that ultimately they'd been led down a path that they didn't really feel comfortable with. And what it brought to the attention of is that there is more need for formalised support within training, according to the views of these 27 surgeons who were interviewed. Now, as well as doing the interview-based study, Pinto also released a survey, which again only went out to two trusts, only went out to vascular and general surgeons. And small sample again, so 47 participants responded. However, of that 47, 1/3 reported traumatic stress of clinical concern. And what they found, and again, this is really skewed because of the sample size, but the predictors of stress were people that used self-distraction as a coping mechanism. So instead of looking at the situation, dealing with it head-on, distracting themselves, and then also being a general surgeon. So when you've only got two specialties, then obviously we can't tell if that is a natural predictor. We'd need to have a larger sample size and look into that in more detail. However, all of what we've looked at so far is this idea that surgeons are second victims, that they are going to be negatively affected when things go wrong. What I love, though, is research like this. So this research was Borges and Osman in 2001, looked at medical specialty choice and personality and whether certain personality types were drawn into different specialties. And the way that they did this was they asked people to declare their specialty and then they gave them the 16-factor personality questionnaire. And what they found is that within surgeons, there was actually a really high level of the factor of tough-mindedness, much more so than GPs and anaesthetists. And it brings to question this idea that I mentioned earlier of, is tough-mindedness something that we train in surgeons, or is it something that is innate within surgeons that allows people to flourish within this area? So, there was a book released by Kevin Dutton in 2012, which was focusing on psychopathy. And he basically used Channel 4 to the best advantage ever. There was a night on, an evening on Channel 4, which sounds like the Great British Bake Off, but it was the Great British Psychopath Survey. And because it was done on Psychopath Night on Channel 4 and had lots of viewers, because it went into all the gory details of psychopaths that have become serial killers and ticked all of those boxes that make it good evening TV, they actually got a really, really large response rate, and he got 700,000 participants taking part in his survey. And he was able to use this information to find out so much about personality traits and things within the general population. He was able, though, from data related to that and to other studies, to create this list of the professions that were most likely and least likely to encourage psychopathy within their ranks. Now, interestingly, surgeons come out as number 5 in the jobs with the highest prevalence of psychopathic individuals. Conversely, though, you have doctors who are at number 9 on the least likely. So I'm guessing from that he removed surgeons and looked at doctors separately, but it doesn't go into as much detail as I would like. However, he questions whether psychopaths are basically overrepresented within the ranks of surgical consultants. And Pegram and Pierce looked at this, and it was in the British, it was the bulletin, wasn't it, of the Royal College of Surgeons, England. It was released, and it's a good article if you haven't read it. But what they looked at, they sent an online questionnaire to doctors in 3 teaching hospitals and 3 district general hospitals. And it was really nice little simple survey with the psychopathic personality inventory and the short form of that. And it tested for all the different factors of what we would have in the DSM, of the Diagnostic Statistics Manual, for the factors of psychopathy. So it ranges from Machiavellian egocentricity through to stress immunity. And what was really fascinating is that when you looked at surgeons' scores, they did score over the average for psychopathic traits. But when you break it down and you actually look at what traits are most prevalent, the most prevalent trait was stress immunity. So you can see in terms of frequency and most prevalency, out of the 172 participants, 78 participants scored well above norm in stress immunity. And it really is this research, this investigation that is missing from the second victim literature. This idea that actually there are some positive traits, some protective factors that are prevalent within surgeons that we need to be tapping into. We need to be finding out what they are. So we don't have to pick up the pieces when things go wrong. You don't have to implement an intervention in place to support someone who is going downhill. What we can do is go back a step and put into training and put into, through medical school, as registrar, first consultancy, training that is going to promote these positive personality characteristics that will allow people to flourish, to give them that protective factor so that when something goes wrong, they already have the tools in their arsenal that they need to keep going. Now, one of the things that we are looking at and we are really interested in is this idea that there is a difference between a complication and an error. Because when I spoke to people, so I'll tell you about a phase that I've been doing, an interview phase that I've been doing. Most people that I speak to are very, very clear on being able to distinguish between something that would be classified as a complication and something that they would consider to be an error. However, when you look at the literature, it seems as though that's been lost. These two terms are so often conflated. And what that does is it doesn't give us that clarity. It doesn't give us a picture of what the impact on surgeons really is. I've spoken to people who are, very resigned to the fact that complications happen, and it doesn't have that much of a negative impact on them. But when they know that the locus of control is within them, when they know that an error has occurred, that they have made a mistake, then that impact seems to be much more significant. So if we bundle these two together, it's going to skew our data. So we need to be able to pull these apart so that we can move forward. Now, we are really aware that this is a very difficult thing to do, that it's not black and white, that there is a spectrum. However, we do really feel that it is a detriment to the previous literature and the existing literature that the difference between them hasn't been examined and looked into. Ultimately, what we are hoping from our research is that we're going to be able to provide better support for surgeons, whether that's post hoc or whether that's putting training in place before anything occurs. And this is really why. So in Pinto's study, so the only real study that's been done within the UK, it was found that basically the support's not as good as it should be. This was the perception of those that took part. They felt that there was a really strong blame culture within the NHS. This was particularly came across in morbidity and mortality meetings, that they felt were much more of a blame game than anything to do with helping to educate people so that people could learn from mistakes. They felt that it was more of a place for personal rivalries than an open forum in which people felt that they could stand up and discuss issues that they were facing. They were reporting that they felt that there was a lack of support from seniors and from management, and that really what younger surgeons were missing in particular was formal mentoring. and that mentoring systems that were in place were too informal and didn't give them the help and support that they needed. So there is a lot of areas really for us to look into. And I was listening to a podcast the other day, and this was mentioned by Urological. He calls it his 3 A's. The idea of awareness, acknowledgement, and action. And that's how we're going to be able to solve some of the problems that are occurring. We need to be aware of them in the first place. And that's why we are doing our research. We need to make sure that the problems that are occurring, whether that be a system-level problem, whether it's an individual problem, is acknowledged so that finally action can be taken. So we stop a downward spiral, we stop there being deterioration. We can stop that and people can get on to moving, to working at a high level again. So in order for us to do that, we have to do some research. And I've alluded to this before. But basically what we are looking at is the extent to which both complications and errors impact upon surgeons in the UK. So we have got a survey that is online at the moment, in which surgeons will complete it and they'll be directed to complete a survey either about their experience of complications or their experience of error. And we're hoping that our research will contribute to the existing knowledge, but will further down the line with subsequent PhDs be able to provide better support and training for surgeons. So we are looking at the personal and professional impact of adverse events. We're looking at psychological variables, so we are looking at coping styles and current well-being. We've got standardised measures in there for all sorts of factors to find out moderating and mediating variables on surgeons when negative events occur. And then what we're also asking surgeons to report about is the availability and efficacy of existing support following adverse events, so when things go wrong. We have a fantastic research team. The person that's missing off there probably is Stephen, who's the second PhD student. So you've already been introduced to Kevin today, and myself. We also have a professor of psychology from Bournemouth University who specialises in the efficacy of training interventions. Helen Balderston, who is a clinical psychologist, and she does a lot of intervention work, especially ACT, so acceptance and commitment therapy. And then Dr. Kevin Thomas, who focuses on decision-making. So we're hoping that within that team and the research that we're doing, we're going to be able to make a significant positive impact. So far, I have conducted a qualitative phase. So I have interviewed 15 surgeons at the Royal Bournemouth Hospital. And one of the things that's come across that I mentioned earlier is that everybody asked has a very clear view of the difference between a complication and error. It's very interesting then when you ask them to give examples of each, that there is still definitely that fuzzy area, that we can't just put it into two camps. They talk about rumination, about going over and over the events that occurred. But one of the things that is really, really encouraging is in that setting that they really get an amazing support from their teams. And that colleague support is very highly valued as a coping strategy when things go wrong. What it does already raise for me, though, just within that small sample, within that one setting, is concerns about the efficacy of formal support. So basically everything that I found out so far is linking to the work that Pinto's already done within the UK. Our research, however, we have just had an article published in the Bulletin of the Royal College of Surgeons, England, which goes into our research. So we've been very fortunate to have the support of the Royal College of Surgeons, England, and the Royal College of Surgeons of Edinburgh in distributing our survey, as well as support from the BMA and from NHS England. So our survey that we are sending out to everybody who is a surgeon within the UK, but predominantly at the moment who is a member of the Royal College of Surgeons England and Edinburgh, is looking into this impact on surgeons. So using standardised measures, asking about personal and case-related information to get a picture, a national picture that is lacking currently. Our survey is available through our website, which is surgeonwellbeing.co.uk. And basically what we need now is for people to complete it. We're in that horrible stage of data gathering where we need to get as many numbers as possible. And really, we need that so that we can make a positive impact on our participants' lives. So we can get that picture, so we know where the support is lacking, so we know where interventions need to be put in place. Did you want to say anything else, Kevin?
Thank you, Kate. About 2 days after our bulletin article came out, I received an email, and this is really typical of the number of the conversations that I've had with colleagues since we started doing this work. I just want to read you an excerpt from this. It says, "Dear Kevin, I've just read and enjoyed your paper in the bulletin. It was very thoughtful and timely and addresses an unmet need. I made a fatal error during surgery a few years ago, and the details of that case are gone into a bit. The effect on everyone was devastating. It always feels callous to talk about the impact on yourself as a surgeon when you know the family have suffered so much more. Unfortunately, my trust didn't know how to handle me or the process, and I was not well supported. There were several inquiries, a review, an inquest, and so forth. I felt and feel very guilty, but I remain disappointed by the lack of support from my employer. I felt I was treated like a criminal first, rather than any duty of care to me as an employee doing his job. I found it very difficult to talk about. It was only the support of my colleagues that enabled me to get through that period." And really, emails like that and conversations like that are why we are doing this work. And this is not about people who are weak or mentally vulnerable. This is about people who are robust, but may not have previously appreciated the fact that what we do and the things that happen to us affect us, and not only us emotionally, but potentially our performance and the decisions that we go on to make. And we would really like to make a difference to that. And what we really need is for the data to develop our research. So what we really hope is that people will go online and complete our survey. If you are a fellow or member of the RCS England or Edinburgh, then you will have received an e-invite. But as is so often the case, the e-invite was buried in the weekly news, and I know from my own experience that these things are easily missed. So please do go on our site, complete our survey, and perhaps consider encouraging colleagues here and in other places to do the same. So we are really grateful for your time and happy in the time that's left to take any questions.